Did I do it? Is it set up? Let me see here. Did I set it up correctly? This is very confusing. Let's see, let's see. If I go to amateur EMS. Are we live? I can't tell if it's working. Is this working? Oh, it's private. No, 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 no. Public. Details. How do I make it public? Okay. Now, is it working? Let's see here. I think I'm good. Let's see. Share, copy. This is very confusing. I think I got it though. Hello, hello. Is that working? I can't tell if it's working. Testing, testing. Maybe I can type in the chat. Hello. Ooh, it's Monique and Gabriel. Monique and Gabriel go crazy. So good to see you, fellas. Aaron, that's a very funny photo that you have there. All right. So what did I want to do today? I wanted to go over some EMS education. Now, you guys are in here first. You can choose whatever topic you want to talk about. If you don't choose a topic, though, I'm just going to kind of go with the flow. I saw somebody commented on YouTube earlier asking for us to go over shock. So I wanted to go over shock. But if somebody else has a topic that they have questions on regarding EMS, let me know. I'm definitely down to go over that. Let me see if this looks good. Ooh, that looks pretty good, right? So, I normally don't go live, by the way. This is all kind of brand new, but I'm planning on doing more live tutoring sessions since we hit 10,000 subscribers, so I should probably start with that, right? So, I like to use paint a lot. I agree, shock and different types of shock. Monique, all right? Monique says shock. That's one vote for shock. I'm good. I'm good with shock also. But what did I want to talk about first? First off, everyone, thank you so much for the 10,000 subscribers. It's very nice of you, and I really appreciate it. Besides that, sorry I haven't been posting that much lately, but I'm trying to pick back up on it. I'm going through nursing school, and I'm nearing the end of it. But, I mean, I can keep talking about it, or I can just go right into shock, right? Shock it is. Okay, Gabriel says shock too. So I even put you guys here. Gabriel and Monique say shock. So we're doing shock. If you guys want to do something else later, let me know. You're taking your NREMT in 2 weeks? Oh man, we can go over all that too. I've got a lot of tips. Hey, I just passed my NREMT 2 weeks ago. Thanks for the helpful videos. Just here to learn and retain info. Morgan, I love to hear that so much. Congratulations. I get messages about that just about every day. So I'm really glad that some of our educational content is working because the whole goal is just for students to pass. So I love to hear that. But good, just congratulations. And good, good, Gabriel, good. You want to knock it out as soon as possible. So we have some different types of shocks, okay? We have hypovolemic shock, I have a really crappy keyboard. Let me see. We have hypovolemic shock. There we go. Oh my goodness, Gabriel, what an excellent decision. We have cardiogenic shock. We have obstructive shock. We have anaphylactic shock. Oh my gosh, I completely screwed that up. Shock. And then we have septic shock. We have neurogenic shock. And really, I'm just pulling this right off the dome, but I think that neurogenic shock isn't, or not neurogenic shock. There's distributive shock that kind of goes into multiple different things here. So let me see what distributive shock has. Distributive shock envelops anaphylactic shock, septic shock, right? Let me see here. And neurogenic shock. Okay. So you got to watch out for this one. It's a little bit trickier. I'm kind of reading up on something really quick. Distributive shock causes and treatments. Yeah. So a lot of people get confused on distributive shock, but we're going to say that this kind of encompasses the three. Let's see. And we're going to say includes anaphylactic shock, septic shock, and neurogenic shock. All right, so which one are we going to talk about first, guys? These three kind of go into this one. So we can pick any of them. Let me go ahead and put these here. A lot of students have trouble with shock, but honestly, once you kind of get it, it's really simple. If not, I'm just going to go ahead and pick the first one. Which shock should we pick first? I'm thinking neurogenic. You want to start from the top? Okay, you know what? Hypovolemic shock it is. All right, so what is hypovolemic shock, right? So a really good way to define it is shock resulting from lack of blood volume, right? So how can we lose blood volume? We can lose blood volume. We can lose blood volume from a couple different ways. So we can have we can lose blood volume from trauma, from severe vomiting, diarrhea. And then we also have some electrolyte imbalances, but you don't really need to worry about that for EMS, right? So we have hypovolemic shock, which is caused from losing blood volume. We can lose it from blood volume, from trauma. We can lose it from severe vomiting, diarrhea. For blood loss regarding trauma, there's a great image that I'm going to pull up here. Let's see if I can find it. Blood loss depending on limb. Let's see if I can find a good image here that can show everything. Blood loss from a femur bleed. No. I don't want to see nasty images. I just want to see the blood volume. Basically, the good rule of thumb is femurs alone, you can lose 1.5 mLs of blood. And once you lose about, let's say, or not 1.5 mLs, femur injuries alone can lose about 1.5 liters of blood. So if you get into a car accident and you have two femur fractures, or two femur fractures, where potentially you're actually openly losing blood, either from a laceration or internal bleeding, once you lose about 2 liters of blood or so, that can already put you into an altered mental status. So it's very dangerous, blood loss. And let's see. Hey Mario, how can I try to get into a career to be an EMT? Okay, we'll get into that next. PX Coffee says, how can I get into an EMS career? We will tackle that next. But anyway, so we can lose blood and we can go into shock from trauma. We can also lose it from severe vomiting, diarrhea, right? So whenever we think about vomiting, we think about patients who maybe they just got food poisoning, or they're going through some type of early signs of sepsis, something like that. Diarrhea, it can be more than just regular diarrhea. It can also be like, let's say if they have hematuria, or not hematuria, but they can have hematemesis. Let me see if I can spell it out right. Hematemesis, puking blood. And then we also have blood from stool. I think it's called melena. Let me see if I can see it. Those are just dark tarry stools. So blood loss from stool, medical term. Okay, we can just say rectal bleeding, right? So we can also have rectal bleeding. And I mean, rectal bleeding is literally just blood from bowel movements. Whenever we have rectal bleeding, we can have two different forms of rectal bleeding. We can have bright red blood, and then we can have dark tarry stools. And how can we differentiate that for our patient? Or like, what does that mean? Oh, what the heck? So basically, if somebody has bright red blood in their stool, or somebody has dark tarry stools or dark tarry bowel movements, what are we thinking for these patients? What does this tell us? So I'll type it in the chat. If someone has bright red bowel movements or dark tarry stools, what does that tell us? Does anyone know? And I'll give you guys a second to think about it. There we go, right? So a lower GI bleed, exactly. So if we have like the abdomen here, I can pull it up. Let's see, intestinal tract. This is a really good image. And this is from the Cleveland Clinic. So basically, exactly, guys, exactly. You guys got it. You guys nailed it. Can I draw on this? That would be so cool if I could draw on this. Draw? Perfect. Can I draw on this? I choose this. So if somebody has a abdominal bleed, and let's say it's in the upper GI, like let's say around this region right here, what are we going to expect? We're going to expect dark tarry stools. So what happens is the bleed that's occurring gets mixed in with the stool while it's going through the intestinal tract, and as it makes its way to its anus or the patient's anus, you're going to see this dark tarry stool coming from their bowel movement. So it's really important that we look at the consistency of their bowel movements. If we see bright red bowel, what is it called? Bright red stool, then what are we thinking? Okay, maybe this patient has like hemorrhoids or something, right? Usually the bleeding will occur right here, right in the by the anal sphincter or the rectum. So it kind of just tells us where the bleed is occurring at. So it's actually really relevant information. Let's see if I can go back from here. So bright red stool or bright red blood from bowel movements. What are we thinking? More than likely it's like hemorrhoids, right? Or very, what is it called? Or GI bleed that's by the anus. We have dark tarry stools. That's an upper GI bleed. Right. And then what can we think maybe what could be causing an upper GI bleed? It could be from like overuse of like things like aspirin, things like that. It can be from overconsumption of like spicy foods. Like I live in South Texas. That's a very common issue. And so they could have like ulcers, things like that, or it could be trauma related. Regardless, identifying the color and the consistency of a bowel movement. If you have the chance, like maybe the patient took a photo, or if they were sitting down on the toilet, you lifted them up from the toilet and you're able to visualize their bowel movements, well, then it can kind of give us a little piece of information about, hey, maybe this is going on. And actually, a contraindication for aspirin is a GI bleed. So if we have a patient who's complaining of chest pain, but as we pick them up from the toilet, we see that they have this bright red or darkish tarry stool, then we can say, hey, they have a GI bleed. I can't administer them aspirin. And I can relate that to the ER staff. So doing your due diligence, being able to recognize these cues really tells us a lot in EMS. So more or less, hypovolemic shock, it's a result from lack of blood volume, and you can lose blood volume from trauma. You can lose it from severe vomiting or diarrhea. So next we have cardiogenic shock. That's a good one. And it's shock from impaired heart function, right? Let's see. Is there a better definition that I can find? It's a pretty decent one. So when can something like this happen? Well, generally this occurs from a heart attack, right? So we think about like a STEMI or a ST elevation causing a myocardial infarction. So if I look up like an inferior infarct online, what does a STEMI look like to me? And if you're an EMT-B student, you don't need to know this. This is just extra information. I'm just pulling this up from a Google search. This is a very good image. This is from LITFL's website. So let's see if I can put it up here. Can we pretty please have access to these notes? I can leave them. I can leave a link at the end of this video. So what I'll do is I will make, whenever I publish this YouTube live video, I will somehow make it to where you can download this for free. That's a great question. Allison, you asked a very great question. Allison asks, can we access these notes for free? Yes, you can. However, I might have to remove some of these imagery, such as like the ST elevation, just because I don't want to, what's it called? I don't want to take away from IFTL. What is it called? Which website did I get this from? LITFL's website, right? Like this is technically, it's their imagery. Yeah, I'm doing this for educational purposes. So it's fine, but it's a tricky subject. No problem. Anyway, so we're generally looking for something like a heart attack, right? And like, what is a heart attack? A heart attack is a lack of perfusion to the heart, right? And so how can we visualize that? Well, for here, for instance, and this is more so for paramedics, we're looking for a possible STEMI. Does anybody see where the STEMI is at? Can anyone see where the STEMI is at? And STEMI being ST elevation causing a myocardial infarction. That's what a STEMI looks like. Not very important. Shane, that's a great question. Shane, if I were you, I would just learn asystole, PEA, VFib, and VTAC without a pulse. That's all I would learn. And realistically, between S and T on the QRST, yes. So we would see it in lead 2, 3, and AVF here. It's a really good imagery of an inferior STEMI. But if I was an EMT-B, what would I do? I would only learn it via a systole or a flat line, PEA, VFib, and VTAC without a pulse. That way, if I put an AED on a patient, and let's say if I'm like an EMT-B and I'm working cardiac arrest on a patient and the family's like, hey, why isn't it shocking? You can tell them, oh, they may be experiencing asystole or they may be experiencing PEA. So they're unconscious, they're in cardiac arrest, but these are two unshockable or not shockable rhythms. But VFib and VTAC without a pulse, hey, why are you shocking my family member? It's because they're in one of these two rhythms, right? So having general knowledge can kind of carry you a bit. But what are we looking for whenever we see ST elevation causing a myocardial infarction? We're looking for this right here. And there's a lot more to it, but generally these three are going to signify that we're seeing a STEMI. Or we're seeing ST elevation in the QRS complex. So the T wave and the S wave are kind of merging together. There's elevation past a certain point. Some people like to measure the boxes. Honestly, if I see the elevation, I can kind of identify it that way. It needs to be in more than one lead location. So like this right here, this is the inferior portion of the heart. And then you have like, this is like your lateral section, your L, where's my thing at? There you go. Your L, your L, your L. This is your anterior region right here. And this is your septal region. Okay, so whenever we're identifying a STEMI, we want to be looking for it in 2 or more of the similar lead positions regions. So like I can't call an inferior STEMI one if I just see it in lead 2. I also need to see it in lead 3 or in lead AVF. So I see it in all 3, so that's fine. So the patient basically isn't perfusing properly. We can see it electrically in the EKG. We can also probably tell from a patient if they're complaining of chest pain, and we can identify it as a cardiogenic shock. And so the heart might start to elevate as it's trying to perfuse more, and then they'll start to present with an altered mental status. So we go from a compensated shock to a decompensated shock, and that's basically for all of these. And then we can start to assume like, okay, what can we do, for instance, if somebody has an inferior STEMI or just a heart attack in general? Do you guys know? What can we do if someone is having a heart attack? Let's say as an EMT-B or as a medic. Does anybody know? And I'll give you guys a second to think about it. That's true. That's true. Excuse me. We can definitely consider calling ALS. Calling ALS is a good idea. Oxygen is a good idea. Nice, nice. We don't do CPR unless the patient, Ajith, if the patient is in cardiac arrest, we'll do CPR. But if they're not in if they're not in cardiac arrest, if they don't have like a GCS of 3, you can't feel a pulse, breathing, then we will not initiate CPR. But that's good for you for pointing it out. Aspirin, right? If they're conscious and alert, we'll give them aspirin, 324 milligrams. Let's see. Only if they aren't allergic, they can swallow. Or we can say they are ANO times 4, right? Alert and oriented times 4 because they need to swallow. They don't have a GI bleed. We can start an IV, right? But what additional meds would we administer, Shane, if we wanted to start an IV? And is there one more medication? You say use a O2 at 15 liters per minute. It really only depends on if a patient is like has an altered mental status, if they're not breathing properly, right? So not atropine. Atropine is used to increase the heart rate, and we don't want to do that. But it's a good suggestion on your part. Basically, what can we do? We can administer nitroglycerin. You mentioned it, Devin, 0.4 milligrams or 400 micrograms sublingually only if what? If we're administering nitroglycerin to a patient who has cardiac arrest, what 2 contraindications are we looking for? So what are the 2 contraindications we're looking for? BP over 90, right? I would say I really aim for like BP over 100 personally, but some texts will say BP over 90, some will say BP over 100. So only if they're not hypotensive, that's a good test answer. But realistically, let's say like 100 over 60. But I mean, realistically, I would never administer it to somebody who is 100 over 60. I would maybe look for more like 120, 140 or so forth. Really like 140 and above. But that's more real life. But for testing purposes, only if they're not hypotensive and no erectile dysfunction medications. Good job, guys. Within the last I've learned it as 24 hours, guys. So, what are some ED medications, right? Internal bleeding, we wouldn't worry about that for nitroglycerin, more so for aspirin. But it's a good point, but we are worried about if they're hypotensive or not. So, what are some erectile dysfunction medications? I'm just going to give them to you guys. Some names are like Viagra, there's Cialis, there's Sildenafil. And yes, different teachers will teach you different things. If your instructor teaches you, watch out for up to 72 hours, then by all means go for it. But as far as the national standards go, from my understanding, it's less than 24 hours. But if Aaron, if somebody did teach you to do it that way, then by all means go with your instructor. So like we have Viagra, Cialis, Sildenafil, we have Tadalafil. When I took my national registry test, they asked me about Sildenafil, so I had to know about that one. Somebody mentioned we can start an IV. This is more so for ALS, right? We can start an IV. We can consider administering morphine. If they're not allergic and they aren't hypotensive. Okay. So it's just some things that we can look for. And again, check with your medical director. This is all just for classroom education wise. But please check your local protocols and everything. But that's more or less what we're looking for cardiogenic shock, right? We're looking for like heart attacks, things like that. And this is like an easy indication. I was working with one of my classmates, and this is a really dumbed down way. Let's say I'm going to look up a really cool EKG here. Right bundle branch block. This is a very cool EKG. Where can I find a good one? A lot of medics will see something like this. And this is more than what you guys need to know. And I pulled this up from, let me give credit to the website at least, from Helio Learn the Heart. I used their website for this image. And medics will see this image right here, for instance, and then they'll ask, "Hey, is this patient having a heart attack?" And how can I tell that this patient isn't having a heart attack right off the back? Now, for EMT-B students, it's okay if you don't know if this is a heart attack or not. Don't worry about it. Can you do a video on an EMR level? I'm a firefighter. I can maybe do that one day, but I'm a little unfamiliar with EMRs. That's why I don't really touch up on the subject. But I do need to kind of visit the topic. But regardless, we have what looks like a prolonged ST elevation, right? Or not prolonged ST elevation. We have a prolonged QRS complex, right? It's a little weird. You can see we have it in a couple different spots here. And so how do we know that that isn't ST elevation? Or why isn't this a STEMI? We compare it to the imagery that was up here, right? Because it's kind of like a wide, weird image. What's the main difference? Well, what I always tell students is when you're looking for ST elevation causing a myocardial infarction, you're looking for ST elevation. So the S and the T wave are kind of matching up, right? And if you learn more about EKGs, which don't worry if you don't know right now, this more so is the S wave right here. I'm going to point, I'm going to point to it right about here. And then this right here is the T wave, right? So again, if I look over here, I circle here. I'm a little shaky, guys, sorry. We have the T wave right here. Then right about here, we have the S wave. And so for it to be ST elevation causing a myocardial infarction, I bet I can draw it really slick here. But again, it'll be a little shaky, right? We have our P wave, we have our Q, R, S. Then we have our T wave. And then for a STEMI, we're going to see something like a P wave. Then we're going to see Q, R, and then there's going to be like a little hump. And then we can't identify the T wave because it's merged in with the QRS complex. No. So this is actually a right bundle branch block. And so I'll get into it in a moment, Shane. But we can see here that the T wave is kind of like merged in, right? But here, I can still easily identify the T wave. Is it inverted? Yes. Is it bad? Yes. It shows a potential lack of oxygen here. But the T wave is right here, right? I can point them out anywhere. I can point them out here. If I look around, I keep on losing the cursor because it's so small. I can point out the T wave here. I can point out, if I go over here, the T wave here. I can point out the T wave here. I know where the T wave's at. This isn't ST elevation causing a myocardial infarction. This is a bundle branch block. What's a bundle branch block? I'm so glad you asked. I'll go into it super quick. Let's see. When we look at the heart, and I just pulled up this image again on Google. This is from the Mayo Clinic. So thank you to the Mayo Clinic for letting me use this for educational purposes. They didn't really let me use this, but again, it's just, this is educational content that I'm talking over, so it should be fine. We have our P wave. And what's our P wave? It's just the atrium. We have our QRS complex, which is the atrium reopening and the ventricles closing. And then we have our T wave, which is the ventricles reopening. So if I can write this out in text. No. Get me out of here. Let's see if I can do this here. The P wave is the ventricle close, or no, is the atrium closing. The QRS complex, or kind of like this big imagery right here, is the atrium opening and the ventricle closing. The T wave is the ventricle reopening or opening. And so, what's going on in this weird image right here, where we can see that the QRS complex right here is almost like beating twice. And what's actually going on, for the most part, for this patient, for instance, they have a right bundle branch block. So the atriums, which are right here, close. We have like our P wave, which I can identify right here. Then we have our QRS complex, and it's like a prolonged weird one. What's going on? It's a right bundle branch, and these two are the two different bundle branches, the left and the right one. It's a block. So it's an either partial or complete block. So right here, we can have maybe a partial or complete block. And so the right bundle branch isn't getting the same signal that the left bundle branch is getting, or it's getting like a prolonged signal. So it's going to have a prolonged beat. So that's why right here we can see what I'd imagine is the left bundle branch, or the left side of the heart for the ventricle is contracting just fine without issues, and then the right one is following almost a millisecond later. And so that's why we have this weird bunny ears looking thing, because these are the two ventricles contracting separately. And then we have the T wave. So we have the P wave, which is the atriums closing, the ventricles, and if it's a right bundle branch block, then again, we have a partial or complete blockage to the right side. So if it's a partial block, then this will conduct from this impulse right here at the bundle of His, and then the right bundle, or the right ventricle will contract next. Or sometimes the left ventricle is going to squeeze. The muscular tissue is going to send a weak signal over to the muscular tissue around the right ventricle, and then that's going to cause it to squeeze, and either way you're going to get this prolonged squeeze. And so we have a right bundle branch block. There's also a possibility for, it's not shown here, but a left bundle branch block, the same exact thing is going on there, just inverted. The important thing here is just being able to distinguish, like, hey, is this ST elevation or not? In this case, it isn't, because we can visualize very clearly that there is a T wave. Now, that's not a foolproof way of defining whether somebody has like a heart attack or not. Some patients will have a completely normal EKG, but they're going to have chest pain 9 out of 10, 10 out of 10. They're going to be diaphoretic. At that point, we don't treat the monitor, we treat the patient. And we still treat them like they're having a heart attack. I'd still give them aspirin, even if their EKG looked completely normal. because I don't want to. It may take like an hour for the EKG to fully develop what's actually going on to the patient. And what's a more definitive answer? It's blood work. And how do we get blood work? Well, we have to get them to the hospital where they can check troponin levels, they can check CK levels, they can check CK&B. Uh, and let's see what you're saying here. If it falls below baseline, it's left bundle branch block right. My medic on my ride along was trying to explain this on our patient. Uh, that's one way to describe it. He was saying it's pretty common on elderly patients to have some type of blockage. It's not really that common, but it can happen to patients. And depending, as long as our cardiologist knows about it, sometimes some patients just kind of have this. But you look at your patient's overall presentation. But what a lot of medics like to do is they like to use something called William Marrow, which I learned from a very smart paramedic. I learned it from my buddy Ian. Let's see. And this is from Geeky Medics. So let's just pull a little image here. So William Marrow, if it's a left bundle branch block in lead V1, so right here, you're going to see like a W. And then for V6, you're going to see an M. If it's a left bundle branch block. So this would be inverted. If it was a right bundle branch block, it would be kind of the opposite, where V1 would have the elevated peak bunny ears, and again, this is from Geeky Medics, and then V6, it would be the opposite. So that's why they say William Marrow. They look at V1, V6, and it tells you whether somebody's having a left bundle branch block. So like William, there's two L's here. We look at the L and we're like, this is a left bundle branch block because it makes the W at V1, the M at V6, and then Marrow, it's a right bundle branch block because you're going to see like two R's there, and it's going to be an M here in V1 and a W in V6. And I go more into detail on that on my EKG videos, but don't feel like you need to know that. If you're an EMT-B, this is well past what you need to know, but it never hurts to learn new stuff. So let's keep it going. We have obstructive shock, which is a very interesting topic. It can happen from a couple different things, but a good definition of it is shock resulting from blocked blood flow back to or through the heart. Okay, let's see here. I have some examples here, but some of them aren't that good. Can I find better examples here? Obstructive shock examples. Because we think of like PEA and things like that. Or not PEA, sorry. Pulmonary embolism. So we can have a couple different things. Can be caused by... Excuse me. Let's see. Can some of you guys give me some guesses? What can cause obstructive shock? Any guesses? You can even use a guess that I threw out. I'll give you guys a moment to think about it. Nice, nice. Super good one, Shane. That's a very good answer. Anyone else? Any other answer choices? A pneumothorax? Okay. Nice. A pneumothorax. What's another one? Anyone else? Hi, Mr. Medicine. Just want to jump in. Thank you for your free EMT study guide. It was so helpful. I was able to pass it in our team. Congratulations, Cam. I love to hear it. Embolism. Nice, nice. Pulmonary embolism. Fantastic work, Cam. That's what we love to hear. So, Shane came up with a great one. Who else threw in something? Shane said some other ones too. And then Aaron also said the embolism with Shane. Good job, guys. So let's see here. We have cardiac tamponade, which is a great answer choice, by the way. So what happens? They have some type of trauma or something occurs where the pericardial sac gets filled with fluid. Copy image. Ooh, this is from Cleveland Clinic. And so basically, there's some type of penetration or some type of trauma that causes the pericardial sac. Graduating my school, that's awesome. I'm sure you're gonna kill it, Shane. It sounds like you have some good knowledge. Exactly, yeah, exactly, Alicion. Cardiac tamponade. So anyway, every time your heart beats, you can see like some of the fluid is leaking out towards the pericardial sac, and the biggest problem is every time your heart beats, more and more fluid gets ejected into into this pericardial sac. So it slowly is strangling itself. And so it has to beat harder to beat properly. And as it beats harder, it fills up more with fluid and more and more and more. And as you build up, your heart becomes tighter and tighter. And eventually, like you can go into cardiac arrest because your heart just can't beat. Your heart can't perfuse to your body. It's very problematic. And so, yeah, I read that. I Google searched it too. Aortic stenosis. I'm not gonna put that one, but I mean technically it's correct. Let's see here. So what can we do for a cardiac tamponade? Well, we can't do anything. You know what we can do? We can get in the back of our box, recognize like, hey, maybe something's going on, but it's really can't identify it. I think what the only way you can identify it in the field is by narrowing pulse pressures or narrowing blood pressures. So the systolic and diastolic are going to get closer and closer together. We can treat them for shock. Yeah, sure. What we can do is we can give them some oxygen. We can potentially start an IV, set them up, but they need a pericardiocentesis. Can we do a pericardiocentesis? No. They may have like some specialty agencies where if they get checked off, they may be able to perform something similar. I've never really heard of it, but there are some EMS agencies where they can do some crazy stuff. I don't know if they can do that procedure. I'm not familiar with an agency that can at this time. But what can we do? We can run. We can go to the hospital, right? So if we start to measure out our patient's blood pressures and we see the systolic and the diastolic getting closer and closer and closer together, and our patient is becoming more altered, maybe we can make some recognition like, hey, maybe this is cardiac tamponade. Maybe we need to get out of here. So that's pretty much all we can do for that. Let's see, pneumothorax. Pneumothorax is a really cool one. There is a telltale sign for pneumothoraxes. I don't know if that's how you spell telltale sign. Is it telltale or is it Tale? I don't know. Either way, there is a sign for pneumothorax. What are we looking for? Does anyone know? What are we looking for whenever we see that somebody has a pneumothorax? What's something where I can point to someone and be like, hey, that guy has a possible pneumothorax? Right, so we can auscultate lung sounds. Exactly. We can look for absent lung sounds. That's perfect. Shane, you got it right. So what are we going to do? We're going to auscultate for lung sounds. We can listen to the left side, the right side, compare the two. So we don't just go, when we assess lung sounds, we don't just go in a random order. Let's see here. Excuse me. Lung sounds. Or can I just look at the lungs? This is from Access Pharmacy. So I'm pulling an image from their website. This is Access Pharmacy. So, how do I like to listen for lung sounds? Can I have my pointer here? Yes, I can. I don't really care too much for listening to the anterior regions. I like to ask the patient to lean forward a little bit, especially like if they're on the stretcher. I'll lean them forward a little bit, and then I'll listen to their lung sounds. And I'll start from like, let's say the top left. I'll probably go right about here. And I'll go from the top left, and then I'll compare it to the top right. So like, let's say I hear clear lung sounds, and I go to the right, I can't hear anything. Then I'll go over here, clear lung sounds, I can't hear anything. I'll do one more time, clear lung sounds, I can't hear anything. And then, oh no, what am I thinking? Potentially the patient is experiencing a pneumothorax. What am I expecting if somebody has a pneumothorax? I'm expecting them to be in a trauma, right? So it's not, it can develop spontaneously, but it's very rare for something like that to occur. More so, I'm expecting them to be in like a traffic accident or something. And now they're starting to present as being like a little bit cyanotic. What's a late sign for a pneumothorax? Maybe like tracheal deviation, right? And so, in the meantime, if I hear absent lung sounds, as an EMT-B, what do I need to consider? What should I do if somebody has a pneumothorax? Exactly. ALS intercept. If I'm a paramedic, what do I need to consider? Any paramedics that know? Or anybody that has an idea of what a paramedic may do? I'll give you a moment to think about it. What would a paramedic do if somebody had absent lung sounds on one side? A needle decompression. But that's for paramedics only. Exactly, Brandon, you got it. And yes, Shane, you got it as well. So we need to do a needle decompression, right, to relieve some pressure. And it's not just a pneumothorax, it can be a tension pneumothorax, it can be a hemopneumothorax, it can be a hemothorax. There's a couple different ways that this can be, and really all it's saying is blah blah blah. Either air is compressing against the collapsed lung and putting pressure onto the just the overall body, or it's blood. Either way, how can we fix this? We can do a needle decompression. And if I'm a paramedic, there's a couple routes I can consider. I can consider going between the second and third intercostal space. So probably right about maybe here, maybe a little bit lower actually. Let me undo that. Maybe right about here in the second or third midclavicular space. More so now they're kind of leaning, or at least my department is kind of leaning towards going between the fourth and fifth intercostal space, where they'll do a needle decompression. And we're looking for like kind of like a rush of air. We're not going to stick the needle too far in because we don't want to accidentally puncture anything else. And we're going to try to look for that relief. Uh, for the rib cage, this is kind of a niche question, but it's good to know. If I'm administering a needle decompression, let's see, and I'll get into that, but it is actually a really good idea. Uh, but I'll go into that in a moment, Shane. If I'm administering a needle decompression, okay, and let's see, if I'm administering a needle decompression, and I'm inserting it in between the second and third intercostal space, do I go above or below the ribs or the rib? So which way do I go? Do I go above the rib or below the rib? If I'm between the second and third intercostal space, do I go below the second rib or above the third rib? Does anyone know? And you can just guess. You don't have to have the right answer. See. You can say above or below. And I don't expect you to know the answer. That's okay. Just throw out a guess and I'll explain the rationale. So Shane says below, and I'll go into your question right afterward, Shane. Any other guesses? All right. So I'll just kind of go into it. We want to go, let's see, above the rib. We want to go above the third rib. Why? Because, let's see. Because, excuse me, the arteries and veins are beneath the ribs. or they're right below the ribs. Sorry about that. Anyway, so we don't want to puncture any arteries and veins that are being protected by the ribs. So instead, we ride above the ribs so that way we don't accidentally puncture anything we're not supposed to. So we go above the rib. So we're going to go above the third rib. We don't go below the second rib. And we do that for that specific reason. What's the last one? Okay, before I move on, you're asking about an occlusive dressing. That's a very good idea. What Shane is referring to is, let's say you got stabbed on your right side right here, right? And so, can I zoom in? Enhance. I can. Whoop. Let's say you got stabbed right here. So then what can we consider doing? We can consider administering an occlusive dressing where we'll do a three-sided dressing. Here, let's say here. Oh, okay, it's that, whatever. Here, here. And this will be like a petroleum gauze dressing. And we'll only tape it three sides. Why? Because whenever the patient inhales and exhales, basically it allows air to be pushed out. But whenever the lungs start to go in, or the patient starts to inhale, they obtain oxygen from their esophagus or their trachea, but they don't receive oxygen from an outward source. So it pushes oxygen out from the pleural cavity or out where the lungs are at. So it relieves pressure. But whenever they start to breathe in, it sucks and creates a seal, since you have it taped three-sided. And it doesn't allow, or it shouldn't allow, any foreign air from coming from a different source. Hello, Tactical EMT. That's a cool name that you got there. Oh, no. So that's generally the rationalization behind it, though. Let's see here. I hope that kind of answers your questions. And then also, like, let's say if it's a gunshot patient and they got shot right here, not only are we looking at putting an occlusive dressing here to try to help relieve some of the pressure that may be occurring from a compressed lung or deflated lung, but we also want to look for where did the bullet exit from, right? Or if it did it even exit. And if it did, we're going to be looking at like the patient's back, but also know it can kind of be displaced a little bit. It's not going to be perfect. So if it started here, it might not exit through here. It may exit through here or something, depending on how the bullet's trajectory is. So if somebody got shot here, for instance, and the exit wound was like right here, what would I do on the back? More than likely, I would place a complete dressing here. I wouldn't put tape on here to try to burp this area, and I would use the backboard to further compress this area. That's a great question. So if somebody got stabbed in the neck, like right about here, technically this is one of these areas, or one of the only other areas besides like the chest or the lungs, where we can consider applying an occlusive dressing. So this is actually somewhere where we can consider the three-sided tape, just like we did for the chest, like right over here. So that's a great question, Aaron. But we would consider an occlusive dressing as well, because we want to try to relieve some of the air that may be trapped within the tissue. It'll be really tricky though. I've never had to deal with something like that. And if the knife is embedded, we're going to try to leave it in place, unless it's obstructing their airway. So if, like, let's say there is a knife that's sticking out here, and normally we would want to bandage anything in place, but if it's actually getting in the way from them breathing at all, like it's actually just obstructing everything, this is one of the only times where we may want to consider removing it and placing an occlusive dressing, but be prepared for heavy bleeding. So we really don't want to have to do that unless it's obstructing the airway. It's the same with, like, if a patient was playing football and they have a helmet on. If it's not bothering their breathing, then I'm not going to mess with it at all. If it's stopping them from being able to breathe properly, or if I need to do airway interventions, then I'm going to remove the helmet. Oh, hello, Arturo Sanchez. Mario is one of my favorite instructors, very intelligent in his career, super helpful, and explains everything in detail as possible as he can. Arturo, oh my gosh, one of the smartest students. You're so right on that, honestly. Thanks, buddy. I'm very glad that you were able to enjoy it. Let's see though. What's another thing? We have pulmonary embolism. Let me get a drink real quick. So, for a pulmonary embolism, what are we expecting that to occur from? Does anybody know? What could cause a pulmonary embolism? And I'll ask this here. What can cause a pulmonary embolism? Does anybody know? I'll give you guys a moment to think about it. If not, I'm just going to say the answer. Just think about it for a moment. A thrombolysis. Exactly, Shane. So what does a thrombolysis mean? A DVT. Exactly, Aaron. A clot. Would you say a clot? But yes, Aaron. So we're really looking for a DVT, but a thrombolysis is completely correct as well. Uh, we're looking for a clot. So what are some of the initial signs that we can see? We can initially see a clot being built up. Where would these clots normally start at before they become a pulmonary embolism? A blood clot in the pulmonary artery? Exactly. You're exactly right. Where do these clots usually form at for the DVT or a deep vein thrombosis? And I'm pulling this image from American Venous Forum. In their lower extremities, exactly, Aaron. Or like Shane, in long veins like the legs. Yep, exactly. Exactly, Devin. Lower legs that get recirculated. So if we see a patient's legs, and I got this from the American Venous Forum, we're going to see something similar to this. And it may not be this obvious. We can see that there's obvious swelling in one leg compared to the other. Maybe the patient was bedbound for a while. So we kind of want to see what have they been doing the past couple of days, right? And so if we see a patient who's presenting with, let's say, like redness in this area, do we want to have them walk to the stretcher? No, because we don't want to potentially disrupt the clot. Instead, we want to keep them as still as we can. We want to basically carry them the whole way onto the stretcher, get them into the ER with as little movement and a change as possible to this position, because we don't want to break off any clots that can either lead to two things. So one of them was a pulmonary embolism, right? So we can expect these clots to cause a pulmonary embolism. What's the other thing it can cause? Excuse me. What's another big issue that these DVTs can cause? Right, so an ischemic stroke. An ischemic or a transient ischemic stroke. So yes, Aaron, a stroke, but more so an ischemic or a transient ischemic stroke. And the reason why I say that is because there's also hemorrhagic strokes, but hemorrhagic strokes are caused by an aneurysm or like a brain bleed. Uh, but for someone like this that's causing from a clot, it's more so an obstruction, right? So, getting a little off topic, a pulmonary embolism is basically a clot that breaks off, and let's see if I can pull it up here. And it's where a clot gets stuck in the artery in the lung and it blocks blood flow to part of the lungs. And so you're going to see that the patient's going to start complaining of like shortness of breath. They may have some chest pain, uh, and maybe they still have adequate lung sounds, but you can see that they are just starting to complain of shortness of breath. I wonder, does pulmonary embolism, does that come with a low SpO2? I don't actually know that. That's something I should know, guys. Sorry about that. Pulmonary embolism, do they have a low SpO2? Yes, people with pulmonary embolism often have low SpO2 as the clot obstructs the blood flow, leading to reduced oxygen in the blood. Okay, so yes. Eventually you should write yes, yes. Sorry about that, guys. But yes, we would expect that. Okay. What are some other shocks? So this confuses a lot of students where they're going to have these three types of shock: anaphylactic shock, septic shock, and neurogenic shock. You may learn it this way, but also understand that all three of these are just distributive shock. So this confuses a lot of students because they may get asked a question, right? Where they'll be like, somebody has uh, urticaria, right? Which is like anaphylaxis. What type of shock are they experiencing? And they're going to be looking like, where's the answer choices is going to say like cardiogenic shock, hypovolemic shock, distributive shock, and obstructive shock. And they'll say, why can't I find the answer? Why can't I find it? It's because it's labeled as distributive shock, or a more encompassing term. They're not being specific with anaphylactic shock. So you need to be able to recognize that distributive shock is an umbrella term and that you have a general idea of what it is. It's not hard to know once you know it, but if you're testing for the first time when you're realizing this, it can be very confusing. So be really wary about this term. But real quick, we have anaphylactic shock. What are they going to present with? It's like a widespread systemic response. So let's see. Why do they cause mass vasodilation? That's what I'm expecting. Compared to something like hypovolemia? Well, there's a couple different reasons, and we'll go kind of into it. So anaphylaxis is a really cool one. Lungs, anaphylaxis. Can I find a good imagery of it? Let's see. Maybe I can just find an image of like a skeleton or something. Anatomy, skeleton. No, anatomy, muscle, person. This isn't good either. Anatomy, organs, person. Okay, this is from Cleveland Clinic. We're just going to copy and paste it. Thank you, Cleveland Clinic. And so what goes on here? Well, let's say you get stung by bees. And let's say you get stung by bees right here. And you get stung by like 5 or 6 bees. Well, what happens? Basically, your body, if you're allergic to bees, will go into a systemic response where it's going to start releasing these cytokines and these histamines all over your body, right? So imagine we're getting a systemic response all over the body because it's spreading out. It's saying, hey, we're under attack. We're being poisoned, right? So we have this huge response here. And so part of what happens in that response is you get like this leaky tissue fluid. And right. So cytokines are released, inflammation spreads, and you start to get like this hypotensive response. But one of the big issues that happens, this is how I like to describe it. Let me see if I can find anaphylaxis lungs. This image is from, let's see if I can find a decent image. This is from Healthline, this image here. And so, this is an okay image, but I'll describe it in some sense. Basically, your body is like, I don't want the irritant or the foreign pathogen, which is just like our bee stings, the 5 that were right here, to get into the lungs. So what does it do? We have our smooth muscles right here that are right around our trachea. It starts to constrict our smooth muscles around our trachea, right? Excuse me. Goodness. Ooh. Anyway, so It starts to constrict our smooth muscles around our trachea to basically block the pathogen from entering our trachea. And so our body, in a sense, is almost like attacking itself because our body doesn't realize that we need our trachea opened to breathe. And so these smooth muscles start to constrict, and that's why we go into anaphylactic shock, where patients are potentially not breathing. We administer a medication like epinephrine intramuscularly that opens up the airway. It relaxes the smooth muscles. It helps vasoconstrict or help like close off the vessels, so we start to lose that vasodilation, and it opens up the airway so it allows our patient to breathe. Now, what's really interesting, this is not the best imagery, by the way, guys, sorry. It's just what I could find at the moment. Can I keep zooming in? Enhance, enhance. What the interesting thing about any type, like let's say if you get any type of bacterial infection or any type of pathogen infection, what happens? Well, the body starts to adapt. It starts to learn and it starts to create like these memory cells where it starts to realize like, hey, I know how to deal with this. The same thing happens like if you get like, let's say the flu vaccine. Well, there is some like controversial reasoning behind the flu vaccine. For the most part, the idea is if you get exposed to this same type of strand of the flu virus, which it does adapt a lot, which causes a lot of issues with the flu vaccine. But anyway, your body will adapt and start to respond faster, which is normally what we want. But if the same thing happens again, let's say you get stung here by like 7 bees a week or two later, or like a couple months later, your body has adapted to bee venom, and so it reacts faster. But the way your body reacts, one of the issues is that it constricts the smooth muscle tissue around the bronchioles or around the trachea. So it does it even better now. And now it starts to really compress against the area. And it keeps on getting better every single time you get stung by bees, if you're allergic to bees, for instance. And so the reaction only gets worse and worse and worse. And there's a couple ways to treat this with like immunotherapy or something, or you can like get re-administered a very small dose of certain allergens and it can help. But that's beyond the point. Basically, we're constricting our smooth muscle around our trachea. It causes a lack of oxygen to our lungs, and then we go into cardiac arrest because it compromises our ABCs, our airway, breathing, circulation. In this case, it's airway. So that's more or less what's going on with anaphylactic shock. We look for urticaria. That's a big ticket item. Hives. Uh, Septic shock. It's just our body reacting to a pathogen. I can't go too much into it, but basically it releases like cytokines. We cause vasodilation. Our heart rate increases as our body is dealing with the increased elevated temperature. And over a period of time, our body just can't adapt to it anymore. We may also have like vomiting, loss of fluid overall. Like let's say if you vomit or you have diarrhea while you're sick, which happens quite often. And our patient ends up going from a compensated shock as the heart rate is increasing to decompensated shock as the heart rate starts to tank and the blood pressure starts to tank. They start to present with an altered mental status. So, sorry guys, I'm running out of time. That's why I got to kind of nip this. I really wanted to go into neurogenic shock. Neurogenic shock, guys, is the coolest shock. And I've seen it before in person, cut out of a person. Perfect. Okay, this is an image of somebody that's trying to sell this on eBay of a cutout, so I do not feel bad about taking this image. So, let's say if you have neurogenic shock. Neurogenic shock, by the way, guys, I've seen it before in real life. It is the coolest thing. Let's say if you fall off of a ladder, right? And then we have our spinal column right here. And there's always like nerves that branch out to it, right? So maybe I should color them. I'll just color the nerves. Can I do it yellow? Can I change this to an orange? Okay. We have our nerves that go from our spinal cord, right? So it starts to travel downwards, keeps traveling down, things like that. This is a really crude drawing of your nerves. Regardless, it still should prove the point. Let's see. Can I make this red? What happens? What are all these different tools? What can happen in neurogenic shock is, let's say you get a injury and you land on your spine, let's say right here, okay? And so you injured this portion of your spine. So from this portion down, your brain isn't able to send any messages to or fro this part of your spinal column down. And what you may not realize is you are always semi-vasoconstricting. That's what the body does. And so it helps maintain your blood pressure. It helps maintain your arteries and your veins. So that way you're able to maintain a certain blood pressure. And so you will have a patient who's going through neurogenic shock where they fell off a ladder and they hit their spine right here and they suddenly can't move their feet or their legs. They can't feel any message, or what is it? They have a lack of sensation from this point down, and they can't send any messages from this point down. And so you get this weird abnormality where the patient starts to turn kind of reddish from this point down. And this is a really garbage way of just demonstrating this. But what's going on? Well, the body is no longer able to vasoconstrict in this region. And so these arteries, these veins, these vessels are basically vasodilating, and it's leaking out into the tissue. And so you're going to see that their tissue from this point on is going to start to turn red. You're also going to see potential priapism. Why? For like males, their genitalia is going to be engorged with blood, or they're going to have like an erection, because the blood isn't being able to be vasoconstricted. Basically, you could think of male genitalia as like a balloon, and we can't stop the balloon from getting filled, just like for the rest of the tissue down here, because the body can't send signals to vasoconstrict. Exactly, they're flooding themselves from the inside, only from this point down. And what's crazy is your body will say, hey, whoa, what's going on with my, let's see what's going on with my blood volume? Why am I losing so much blood volume? And so what's really interesting is your body is still acting completely normal from this point on. So we're going to start to see cyanosis of the fingertips, right? Or we're going to start to see bluing of the fingertips. Why is that the case? Why do we get bluing of the fingertips while we're getting vasodilation from this point down? Does anyone know? And realistically, we might even see bluing of their whole upper extremities in general. Why are we... Because the top part of the body's running out of blood. Right. Exactly. Mud Dog and Blue. Shane Presley, because the oxygenated blood isn't returning. So that's a good point. But what's going on intrinsically is the body's actually vasoconstricting, because it's still working fine. Your body, at the end of the day, cares about perfusing your brain, your heart, your lungs, your kidneys, right? Especially like your kidneys, your heart, your brain. Those are the big dogs in the body. And then like your liver, things like that. But it cares about perfusing your main organs. So what's the first thing it's going to be like, hey, you're not getting any blood right now? It's going to be your upper extremities if it can help it, right? And normally your toes would also become blue, but why aren't they becoming blue? It's because our body can't vasoconstrict down here, because it's lost the sensation from this point on. It's going to keep on trying to vasoconstrict. In this general area, we may see cyanosis of the lips. Yes, it's exactly, Shane. It's vasoconstricting to try to retain blood flow, at least somewhat, to the brain, the heart, the kidneys, because it's doing its job. It's saying, I don't know how I'm losing blood. Exactly, my dog. It's rerouting the blood from the extremities to feed the important organs. You're exactly correct. It's super cool. It's Shane. It's like it's the coolest thing ever. And then sometimes you can see priapism, and usually people joke around and they'll laugh about it. But like a patient will have an erection because if you look at the male genitalia in an anatomical sense, it's really just a bunch of deflated balloons that need blood flow to become erected. And so it's such a cool phenomenon. And I've got to see it before, and we brought this patient back to life. one time because they fell off a ladder that was like only 3 rungs high, but they landed on concrete, and it was the most amazing thing to visualize. We didn't recognize it at the time till after they physicians were able to fully examine the patient. Anyway, let me see here. So it's your body, exactly, Gabriel. It's your body keeping you alive. That's exactly it. Let me see. Exactly. If you're, let me type out one thing real quick. With prepping for the EMT-B, check out medicine. Let me see if I can do this right. We sell a study bundle that's helped a lot of students. It's a really cool phenomenon, guys. Anyway, fellas, I have my clinical at 4:30, so I have to leave at this point. But I'm going to post this live video in hopes that it can help other students that may have questions regarding shock. Yeah, shut off the non-essentials to keep the important stuff going. Exactly, exactly. But real quick, I am going to link my stuff just because I can, I guess. So what is this? This is amateurmedicine.com. I created it to help students that are struggling with the NREMT-B. And I'm probably going to do this on every live at the end of it. And no problem, Shane. You're a great student. You really knew your stuff. What's so great about this test prep? There is a vital signs portion, all included in this bundle, that you can like practice your vital signs, things like that. A lot of students don't realize they don't know their vital signs, so they take the National Registry test. There is a 500 practice EMT-B exam where like you have practice questions, you have practice exams. There is a GCS, APGAR, and Rule of 9 section where you can practice those to master it. You can download from these PDFs, and there's also a 26 fully filled out, updated EMT-B study guide, along with the video that you can use to help you prep. I just had to throw that in real quick because I am a shill for my own stuff, right? But yes, Shane, well, you did a really good job. Don't worry about it. The whole thing's going to be uploaded on YouTube. You just go to live and you'll be able to see it there. I should post it a little bit later, but I do have to rush to my clinical. But again, if you have a friend that's struggling with the NREMT-B and they're looking for a test prep, or if you are as well, I'd highly recommend checking out amateurmedicine.com. We did a great job, but you can also just message me on Discord or on any YouTube videos, and I'll try to comment it. I'm trying to do more live videos since we reached 10,000 subscribers. I think that they're a lot of fun, and I like interacting with you guys. I have a lot of plans. Alicion, thanks for joining, buddy. I really do appreciate it. Of course, Gabriel. I think I know Gabriel, by the way, because I recognize that name. But with that being said, everybody, I'm going to go ahead and head out. Thanks so much for joining again. And if you have any questions, feel free to send a message. I'll be looking for it. Yes, sir. See ya.